Hello everyone. Hearty welcome to Learn from the Legends, our International Neonatology webinar series, the first session in this year 2025. Happy New Year to all our respected attendees. I am Dr. V.C. Manoj, President of National Neonatology Forum India and the Chairman of the Organizing Committee for Learn from the Legends. I have great pleasure to invite and welcome you all to today's session. It's going to be slightly different from the last few sessions we had. It's going to be a roundtable discussion. And this time we have a galaxy of legends, not just one legend, galaxy of legends. And we will be discussing neonatal cardiology, specifically the bradycardia in a newborn. So without wasting any more time, let me welcome the legendary team, cardiology team today, led by Professor Seshadri Balaji from Oregon Health Sciences University, USA, and Professor Krishna Kumar, Amrita Institute of Medical Sciences, Kochi, India. We also have other cardiology experts like Dr. Navaneetha, Sasikumar as well, and many others joining them. To moderate today's discussion, I have great pleasure in inviting two good friends of mine, Dr. Archana Bilagi from Bangalore, India, and Dr. Gopal Agrawal from Gurugram, India. With this brief intro, let me invite our moderators, Dr. Gopal and Dr. Agrawal and Dr. Archana, to kindly take over and let's discuss neonatal cardiology. Thank you.
Thank you, Dr. Manoj sir, for giving this opportunity to moderate this important session. And first of all, congrats to you for carrying this legacy of Learn from the Legends for 4.5 years. It takes real effort to continue so long. And believe me, everyone is benefiting out of it. To have a session on bradycardia in a neonate in India itself tells us how far we have reached in this lectures. So just to say bradycardia in a newborn, any heart rate less than 100 for us, for a neonatologist, it would increase the heart rate of a neonatologist. So it would cause tachycardia in a newborn. So particularly if a baby is born less than 100, it has happened once with me over last 10 years that I faced a sinus brady or whatever you call it, heart rate of 80, and I actually panicked at that point. So we tend to forget that it could be just a block or a congenital heart block or a malformation or anything else. So that doesn't come to our mind. So probably after this session, after 1 hour, we'll be more wiser and probably we'll think of blocks at some point in our practice. So it's my pleasure to introduce Dr. Seshadri Balaji as one of the experts. He doesn't need any introduction in pediatric cardiology. So he has done his MBBS, his MRCP, CH, and PhD, and is currently a professor of pediatric cardiology with expert and keen interest in pediatric electrophysiology. He's currently in Oregon, USA. Just to complete his bio, he completed his MBBS from Stanley Medical College, Madras. Then he moved across the world. He acquired various degrees and expertise, and he completed his PhD in arrhythmias after surgery for congenital heart disease from Amsterdam, Netherlands. He has published more than 130 papers, peer-reviewed papers, and multiple chapters and books. I don't think he needs introduction beyond this. He's an expert and the thing in pediatric cardiology. So I would hand over to Dr. Archana to introduce my other experts. Welcome, Dr.
Yes,
Balaji.
good evening. Good evening. I'm here to introduce the next expert, Professor Krishna Kumar. Dr. Raman Krishna Kumar is currently the clinical professor and head of the Department of Paediatric Cardiology at Amrita Institute of Medical Sciences and Research Center in Kochi. Now, he has helped establish the pediatric heart program at the Amrita Institute in 1998. And under his leadership, the program has acquired global reputation. Now, a significant proportion of the national workforce has been trained at AIIMS. The pediatric heart program at AIIMS Kochi was awarded the BMJ Award for Quality Improvement in 2014 for delivering outstanding clinical outcomes. And he has trained a proportion of healthcare personnel in pediatric cardiology. Now, the program is a Children's HeartLink Global Center of Excellence, and the department was awarded the status of a Center of Excellence in Research by the ICMR. His chief interests relate to epidemiology of pediatric heart disease, developing cost-effective clinical strategies and population-based programs for pediatric cardiac care in low-resource environments. Now, he was awarded the prestigious Sitaram Jayapuria Award for Excellence in Medicine and Healthcare in India for the year 2022. He is also a member of the steering committee of the International Quality Improvement Collaborative on Congenital Heart Disease, and he has served as a member of the Rheumatic Fever, Endocarditis, and Kawasaki Disease Committee. He has published over 260 index original and review articles, including and has written four major textbooks, or co-edited rather, including the Anderson textbook of pediatric cardiology. Welcome, Professor Krishna Kumar. Now, Dr. Gopal will introduce the next expert, Dr. Navaneetha.
So we have one more expert, Dr. Navaneetha Sasikumar. She is currently Associate Professor in the Department of Paediatric Cardiology at Amrita Institute, Kochi. And her interest lies in congenital and structural cardiac interventions and adult congenital heart disease. She completed her DM in cardiology at Lokmanya Tilak Hospital, Sion, Mumbai. And from there, from there on, she moved on to SICKIT, Toronto, to complete her fellowship in pediatric cardiac intervention. She has keen interest in adult congenital heart disease clinic, which is one of its kind in India. Currently, what interests me is like she has developed an app called the Smiling Heart app, which helps pediatricians and neonatologists to do a bedside echo. Probably that is under research, and we all look forward to that outcome of this app, and probably we all will benefit. Welcome, Dr. Navaneetha. So just to give an overview of today's session, so we'll have more of case-based discussion. So we'll have three cases here. First case will be predominantly bradycardia in a newborn, and that will be by Naimisha. And Dr. Krishna Kumar will be discussing about the case, and we'll have some discussions about the case. After completion of the case and discussion, we'll move on to the second and third case, and we'll have further discussions about that cases later on. And probably we'll take up the questions, and I would request all the delegates to put up their questions, the queries in the Q&A section. Over to Dr. Krishna Kumar to take over the session, and Dr. Naimisha to start the case. Please.
Now, to introduce Dr. Naimisha Yanduri. She's a DM resident at Amrita Institute of Medical Sciences in Kochi.
Thank you, Dr. Gopal, and thank you very much, Dr. Archana. We are now, I'm going to start sharing my screen, and I'm just making sure that it's all visible to you, all of you. Again, thanks to Dr. Manoj for such an extraordinary opportunity to be a part of what I think is very important, because this is an area that I think that needs to be introduced to the neonatologists. And I'm especially thankful to Balaji for having agreed to be a part of this whole initiative. So I'm sorry, can you see my screen? Are you able to see my screen? Hello?
Yes, sir, but
Yes,
I think you are not in the presentation mode.
It is in the presentation mode as of now.
Okay, but
You're
what about the others?
Computer
We are
screen
unable
is
to
not a presentation.
Okay, can you, when I go to the next slide, Naimisha, you can start presenting the case. I'm going to just move to the next slide and see if is it still in the presentation mode now?
No, sir. Sir, we cannot see the presentation, sir. It's your computer screen can be seen though.
Okay, I'm going to restart sharing screen and just get me one more chance to do it. And let's see if that comes through. Now it should work through.
Yes.
Yes.
sir.
Okay. So is this in the screen sharing mode? You're able to see, right?
Yes, sir. You can see
Okay,
now, sir.
I would ask Naimisha to now present this case.
Yes, sir. Good evening, everyone. I hope I'm audible.
You are, definitely. Thank you.
Today, I'm presenting the case of a preterm baby with bradycardia. The baby was born to a 31-year-old mother with obstetric index of G4P2L2A1. Her pregnancy was complicated by gestational diabetes mellitus. There was history of maternal fever in 7th month of gestation, which was not associated with rash or jaundice, which was treated with oral antibiotics, after which it resolved. Antenatal scan done in the 3rd trimester showed severe non-immune hydrops with fetal ascites, pleural effusion, and pericardial effusion. Also, fetal echo showed bradycardia with a fetal heart rate of 80 per minute and myocardial dysfunction. Maternal autoimmune workup, that is anti-Rho, anti-LA antibodies were negative. A male baby was born by emergency LSAS in view of fetal hydrops at gestation age of 32 weeks, 4 days, that is moderate preterm, with a birth weight of 2.19 kg. Baby cried immediately after birth. APGAR was 8 and 9 at 1 and 5 minutes respectively. At birth, the CFT was prolonged and heart rate was noted to be 48 per minute with a clear chest and soft abdomen. So baby was admitted to NICU after birth, needed resuscitation after birth, initially with CPAP, but eventually needed ventilation. Baby was gradually weaned off the ventilator, required CPAP for 6 days and transitioned to HFNC for 4 days and eventually to O2 prongs, which baby required for 6 days. Echo showed a structurally normal heart except for a small ASD and normal ventricular function. And baby was started on a medication called osipenilin, which goes by the trade name of Alupent. It was started at 0.1 mg per kg per day. This is a beta agonist that we give to increase the heart rate. And baby was also started on IV antibiotics in view of probable sepsis. Nutrition-wise, baby was initially on total parenteral nutrition, but gradually transitioned to full feeds via the OG tube. So baby was referred to us at 36 postnatal day, at which point the corrected gestational age was 37 weeks and 5 days, with a weight of 1.9 kg in contrast to a birth weight of 2.19 kg. And baby was on orogastric feeds. Heart rate at admission was 70 per minute. Saturation was 97% on room air. Pulses were well felt, and echo showed a normal biventricular function and a structurally normal heart.
Okay, I'll just stop at this minute, and maybe if there is anything that merits discussion before we show the ECG, we can welcome that. Dr. Balaji, do you want to sort of?
Yeah, thank you, KK. So, as you can see, this child is presenting with bradycardia and hydrops, fetal presentation of bradycardia and hydrops. So in the pediatric cardiology world, when we see this, they absolutely, as you saw there I think in the previous slide, they did maternal autoantibody check. So, I mean, whether you call it anti-Rho, anti-La, or the new terminology, which is anti-SSA and SSB antibodies, it's important to check for this because this is the most common cause of neonatal or fetal congenital heart block. So as soon as they notice this, now, in fact, even in fetal life, we can make a very specific diagnosis of heart block and the type of heart block. I'm sure many of you know there are 3 degrees of heart block: 1st degree, 2nd degree, 3rd degree on the ECG. When it is so bradycardic, you can clearly surmise that it's definitely not 1st degree. It must be either 2nd or 3rd degree. And by careful echocardiography with M mode, you can see when the atria are contracting, when the ventricles are contracting. And usually you can put a cursor, which includes both the atrial and the ventricular myocardium, and you can look at the ratio. So because we cannot do a fetal ECG easily, I mean, there are sophisticated ways of doing it, but let's not go into that. The fetal echocardiogram can be very helpful. So what I would say is, as soon as this child had been noticed to be having fetal high drops and bradycardia, that should have been initiated. That is something that obstetricians have to keep in mind. And neonatologists, you have to pass on the message and pressurize the obstetricians, etc. So that what we call the perinatal specialists are the ones that have to do this. But anyway, this child developed high drops, was born, and now we have both. Not only the presence of high drops tells us not only that the child has got bradycardia, but hemodynamic compromise as a result of bradycardia, that the cardiac function is compromised. Now, I would say, at least in my experience, KK, you can correct me, more than 90% of the babies with fetal or congenital heart block do not have hemodynamic compromise. They do not have high drops. They tolerate it very well. They are born. And generally speaking, as long as the heart rate and what we call the escape rhythm is better than 55 to 60 beats per minute, the baby is usually tolerated well. So the first thing that concerns me is this child is not tolerating it even at 70 beats per minute or 80 beats per minute. It's a little bit unusual, but still the issue is this baby has some, obviously this is not autoantibody mediated congenital heart block. We can see that the anti-Rho and anti-La antibodies were negative in the mother, but the mother had some kind of a viral infection. Maybe this is some kind of a fetal myocarditis, which both compromise the AV node and the cardiac function, resulting in this sort of a presentation.
That seems like a reasonable situation. Here is the ECG that how do you want to approach this so that we have a really useful discussion here?
Let me see if I can get a pointer. How do I get a pointer?
I can. I am the one with the pointer. So tell me.
Okay, that's okay. So, I mean, it's pretty obvious that this child has complete heart block. You can see the P waves going at a much faster rate. Dr. KK is showing where the P waves are. You can also see the QRS complexes are going at a completely different heart rate, much slower. So there is atrioventricular dissociation. Now, atrioventricular dissociation is the most characteristic finding of heart block. The second thing that is very noticeable in this case is that the QRS complexes do not look normal. Especially in neonates, you see an exquisitely narrow QRS complex. So the entire ventricular myocardium is depolarized within a very short space of time, usually, I would say even, 50 to 80 milliseconds. Whereas in this case, you can see here that the QRS complex looks a little wide. That immediately tells us that the ventricular escape rhythm is originating one of two possibilities. It may still be originating in the AV node. So if you imagine the AV node, one of the things we now think, unlike the olden days when we used to think the AV node was a very, very tiny little structure about the size of a mustard seed, we don't think that anymore. We think the AV node is a much bigger structure, and most likely the block is at a more higher level in the AV node, and there are automatic cells that have the ability to create action potentials lower down in the AV node, which are depolarizing the ventricles. So when the ventricular depolarization goes through the His bundle, through the Purkinje fibers and activates the myocardium, you should get a very, very narrow QRS complex. So one of the things that I always tell residents and fellows is there is only one way the QRS complex can be narrow. If the QRS complex is narrow, that tells you that the ventricular depolarization was happening very fast and that it was due to conduction through the His bundle. So the two possibilities here are the depolarization is starting in the AV node, but that there is some what we call infrahisian delay. So maybe the Purkinje fibers are not working normally and there is some delay in activation of the myocardium. That's one possibility. The second possibility is that the actual action potential is coming from even further down, not in the AV node, but lower down, maybe in one of the fascicles, either the right or the left bundle or one of the fascicles. and that is causing a slightly broader QRS complexes. So there are, the presence of high drops, the presence of a broad QRS, etc., and significant bradycardia here, all of that tells you this baby is not tolerating this rhythm and needs some form of therapy right away.
Perfect. And this is exactly, the high risk pointers are wide QRS, very slow heart rate. And there are a few others that we worry about as cardiologists, which is, you can just touch upon it, Dr. Balaji, which is the presence of frequent ventricular ectopics, some form
Yes.
of, yes.
Yes. So we don't, just because you have congenital or complete heart block does not mean automatically that you need a pacemaker. We look at certain criteria, and the most important criterion is symptoms. And in this child's case, even though the child is too young to come and tell you that they have symptoms, you can see the myocardial compromise and the presence of high drops tells you this child is symptomatic. Okay, this child has got cardiac failure symptoms. Excessively slow heart rate. So we generally use a cutoff of around 55 beats per minute in neonates. Maybe you can give yourself a 5 beat per minute cushion. Generally, if the baby's heart rates are lower than that, they need pacing. Presence of a broad QRS complex, as Dr. KK already mentioned. Presence of various, an excessive presence of premature ventricular beats is a indication. And also, sometimes you can have prolonged pauses. Technically, in cardiology, any pause between two RR intervals greater than 3 seconds is considered an asystole. Okay, any pause greater than 3 seconds is considered an asystole and is automatically considered an indication for pacing.
So I've got this next slide, Dr. Balaji, that we are looking at, which is to discuss some management options. As it worked out, this patient was received from another hospital, and we were in communication with the other hospital because there was this, the details were shared with us a little earlier. It took a little while before we could organize the logistics of the transfer. But when we received the child, these were the 3 options that was in front of us. And you can see that we can maybe briefly discuss the challenges with each of these 3, and then we can go on to describing what we did.
Yeah. So, there is a 4th option, which is transcutaneous pacing, which is quite painful. And you would have to intubate and sedate and have a very calm child in order to do that. Drugs like orciprenaline, salbutamol, terbutaline, isoprenaline, intravenous epinephrine, they've all been used. They're all chronotropic agents and can increase the heart rate. So even in older patients with complete heart block, for instance, they may have a resting heart rate of let's say 50. When they exercise, their heart rate will go up. So adrenergic stimulation can be used as a temporizing measure, but usually that is a very temporary phenomenon. And the danger of using these drugs is that they're all proarrhythmic. All of them are proarrhythmic. They are likely to cause problems such as ventricular tachycardia. So they are double-edged swords and have to be used very cautiously. And especially if you have, one of the dictums of cardiac electrophysiology is that bradycardia begets tachycardia. Bradycardia leads to cardiac dilation and stretching. And whenever myocardium is stretched, if you stretch the atrial myocardium, you come up with arrhythmias like atrial fibrillation. If you stretch the ventricular myocardium, you come up with problems like ventricular tachycardia. So this has to be very carefully done, and it's not an easy thing to do. Obviously, permanent pacemaker placement, the basic treatment for any symptomatic bradycardia is still, I should say, unless it is transient bradycardia. Of course, if you have vagal bradycardia, etc., and it's a transient phenomenon, no need to treat. But any persistent symptomatic bradycardia, the ultimate treatment is always a pacemaker. Okay.
Okay, I'm quickly going to go through 3 questions that have come in the chat box, and I thought we should quickly address them. The first thing, this question relates to Holter. Is there a need for a Holter? Of course, given this severe bradycardia on the ECG, is there additional value of the Holter? Dr. Balaji, you can quickly touch upon that.
Yeah. You know, if you have the baby in your neonatal intensive care and you are monitoring the baby, you're basically doing a Holter monitor. So Holter monitor is obviously very important and useful, but that is basically for patients who you are managing on an outpatient basis. If you're managing on an inpatient basis, there is no need for a Holter monitor. But any kind of monitoring, frequent recording of the monitoring, and making sure that the nurses or the doctors who are managing the patient are taking some kind of a screenshot, and reviewing it. You know, especially with modern technology, it's very easy to take a photograph or a screenshot. You can, if you don't have a pediatric cardiology immediately on site, form a linkage with another pediatric cardiologist and text them or WhatsApp them and say, hey, I have a case. Can I show you a ECG strip from that case? And send it to them. That is just as good as a Holter monitor.
2 quick questions from one is about what's the acceptable limits for bradycardia during sleep in a newborn, in otherwise normal newborn?
Yeah, this is a very difficult question to answer, believe it or not. First thing to say is, if a child has got sinus bradycardia, it is very, very rare for that to be a pure cardiac problem or a primary sinus node problem. Not that primary sinus node problems don't happen, they're exceedingly rare. The most important causes of persistent sinus bradycardia are the following. Hypothermia is probably the most important cause. Hypothyroidism, another very important cause. Okay. Raised intracranial hypertension. All right. Things like, so the bottom line is the most common causes of bradycardia in anybody, sinus bradycardia, are extracardiac causes. So severe sepsis, for instance, a neonate with severe sepsis can present with severe bradycardia. They just cannot mount a tachycardic response, for example. So statistically speaking, you have to look outside the heart first. And once you have excluded all those causes, then you can come to the heart and ask, okay, is this cardiac? And the most important clue, if it is cardiac, is that it'll be familial. The few very rare conditions that we see, and we will see it in the next cases that are presented, long QT syndrome, especially SCN5A mutation, sodium channel mutations, can present with severe bradycardia and may need a pacemaker for that reason. But
that's the second question on bradycardia associated with electrolyte disturbances that we'll cover in the next case.
Yeah.
So in the interest of time, I'll move on because questions are flying in quite rapidly. But
sure.
I think we'll move on with the rest of the case and continue the story. So this was the 4th option that we thought of, Balaji, of what we thought was one of 2 options. I think we can just dwell briefly upon the challenges with permanent pacemaker at this age.
So the main challenge of pacemaker placement is the size of the pacemaker. So the baby's size is decent. So I would say 1.5 kilograms and higher, we can usually place a pacemaker because we now have access to a very, very small pacemaker. I'll see if I can show you a picture of that. If you, Navaneetha, if you have a few minutes.
You can share, sir. You have the option to share. If you want, you can share your screen.
I'll stop sharing if you have the option to share.
No, it's okay. I have to
go ahead.
Yeah, I have to get it for you.
You can locate it and we will find a way to share.
Yeah.
I will share. I mean, I can do it from here. Do you want me to do it from here, sir?
No, it's okay. Just give me a second. So we can do permanent pacemakers in very, very small children because we have very small pacemakers. Not that I'm a particular advocate for a particular pacemaker company, but the smallest pacemaker we have right now, there are 2 companies. Medtronic has got a pacemaker that we can use called a novel pediatric implantable pulse generator, or IPG. And St. Jude, or what is now Abbott, has had a pacemaker called a Microny, which is about the size of a small coin. The availability of these two pacemakers has helped us take care of these very small children. But if the child is very premature or has high drops, and because of the high drops, the surgeons are worried about the edema of the tissues, the ability to hold sutures, etc., then we might opt for a ventricular wire placement, either transvenously or more often epicardially by a sort of a mini incision to place a wire and improve the heart rate and grow the child until they are big enough to get a permanent pacemaker.
Which is exactly what we chose, because the transvenous option was a bit daunting and quite invasive for this little child. So tell us, Naimisha, you can go on what happened.
Yes, sir. At 40 days of life, temporary epicardial pacing wire insertion was done through a partial median sternotomy. If you can see in the X-ray, there is a sternal, next to the sternal wires, inside the heart, in the RV myocardium, we can see the pacing wires. We can see 3 pacing wires that are within the myocardium that are brought out onto the surface. And we connect that on the right side of on the right side, you can see the wires, the orange wires that are brought out of the skin and connected to a pacing box. The black box is what we refer to as a pacing box, where we can set the heart rate and the output. So by convention, the atrial wires are brought out from the right side of the sternum, and the ventricular wires are brought out from the left side of the sternum. So this is not of the same patient, but this is for representation. We can see the pacing wires that are connected to the pacing box, and where the 130 is the heart rate that was set, and 4 is the output that was set.
Okay, and repeat was taken care of in the NICU, right?
Yes, sir.
Okay, and how many days did we have to do that?
So we had to wait for a month almost, like at 1 month, 26 days, at a weight of 2.2 kg, baby underwent a epicardial permanent pacemaker implantation. As we can see on the right side in the X-ray, there's a pulse generator that was placed in the abdominal pocket beneath the rectus muscle, and there's a lead that was connected into the LV myocardium, which was a screw-in type of lead.
Now,
And
if you think about this pacemaker, Dr. Balaji, we are not using either Microny, nor are we having access to the other Medtronic pacemaker. One is there are a couple of issues which are quite unique to India, which the audience should get familiar with. Both these pacemakers are not covered by the conventional lifetime warranty that's offered for all pacemakers. Lifetime warranty allows us to change the pulse generator as the patient's battery gets exhausted. Now, that's very important for our Indian patients. Unfortunately, the Microny, as well as the other Medtronic pacemakers, do not provide this, and also their life is limited, because when their pacemaker is so small, the battery life is also limited to maybe at the most a year or 2. And then we are left with the option of trying to find resources for a new pacemaker altogether.
Yeah, absolutely. I mean, as you can see, this pacemaker looks incredibly large. When if you have to, I can show you.
Your pacemaker should be about a quarter of the size, I presume.
So
correct?
I don't know if you can see my what I'm holding up in my hand.
No, I will stop sharing screen, and then we can pay attention to what your yeah. So you can show up your yeah.
Yeah, you can see this is the size of a standard pacemaker that we use typically, and it's really small. But as you can understand, less than 2% of the pacemakers worldwide are placed in children. 98% are placed in adults. So these companies, their main market is adults, and so they're made for adults. But we now have this, we have some options, and I'm sure eventually these options will be available. But in the meantime, you have to do temporizing measures like what was done in this child. The important thing is to stabilize the child with a pacemaker. Now, in case you're wondering, we have two options, right? We can either do what is called a single chamber pacemaker. Like in this case, you can see if the pacemaker is only pacing the ventricle. And they did a very nice job here, which is to pace the left ventricle. What we have found over many years of research is that pacing the right ventricle can create a condition called pacing-induced cardiomyopathy. So whenever you pace, you are creating an abnormal depolarization. The wave is not the same as being depolarized through the His bundle. And persistent pacing from the right ventricle can be associated with pacing-induced cardiomyopathy. It is significantly less if you pace the left ventricle. So pacing the lead on the left ventricle and connecting a single chamber pacemaker, even though you do not have AV synchrony. So you can see in this slide, after the pacemaker implant, you can still see there is AV dissociation. You can see the P waves are not associated with the QRS complexes. They are happening sometimes before, sometimes after, sometimes buried inside the QRS complexes. So the atria and ventricle are not in synchrony, but that's okay. The fact that you have improved the heart rate is the most important thing. AV synchrony provides a little bit of additional benefit, but it's not critical. The improvement in heart rate itself is usually sufficient to help stabilize the child and get them to a bigger stage. And when they're older and whatnot, you can always go in, put in an atrial lead on top, and then connect it.
Naimisha, you can complete the story and then we'll take some questions.
Yes, sir. So baby had a long ICU course with requiring multiple reintubations, then nutrition-wise to be cared for with initially TPN and followed by OG feed. So finally, baby was discharged at 2 months 25 days at a corrected gestation of 1 month 6 days with a weight of 2.9 kg. Length and head circumference are as mentioned, and baby was on oral feeds, hemodynamically stable. Current status: baby is 3 months 21 days old, weighing 3.9 kg. Has adequate weight gain since discharge and is on full feeds via formula.
Okay, that's fantastic. What I'm going to do is try to answer some questions directly because the number of questions are quite substantial. And we'll finish this case and take some discussion from the neonatologists in the panel because that'll be of great value to the others. So I think we are done with this particular case. I'll stop sharing for a second. And I would invite the panel to get into this discussion and ask questions from the neonatologist perspective.
I think the challenge begins when a fetus is diagnosed with hydrops and there is significant bradycardia. There is one question: how do you prepare for this baby at birth? The challenge would be, of course, the hydrops, the respiratory depression or respiratory compromise would be there, cardiac compromise is there. Do you start on drugs right away? How do you approach this baby at birth?
So if we had this baby here, we would have had a team all set up and ready. The baby would be usually born by cesarean section. We would not allow vaginal delivery. And as soon as the baby is born, neonatologists and cardiologists and cardiac surgeons will be all available and ready. The baby will typically be whisked straight away into a procedure room where the baby will get lines placed, chest tubes if necessary, pericardial drain if necessary, and a surgeon will be available to immediately do a sternotomy. So the baby obviously will be intubated, anesthesiology will be there, do a mini sternotomy, put at least a single lead, connected to an external pacemaker like here. And it's a lot of organization and teamwork, but that is what has to be done. So these babies have to be born in a specialized center that has all the capabilities. So as soon as you recognize it in the fetal life, so if you recognize congenital heart block in the fetal life, so if you suspect heart block, you have to immediately involve a cardiologist who has some experience and expertise in doing fetal echo. So by doing the fetal echo, you can then diagnose whether it's complete heart block or not. So let us say it is complete heart block. Then you have to keep serially following the baby with periodic, and this the OBGYNs can do. They have to look at the fetus and see if there are any signs of eye drops, right? And if there is no signs of eye drops, we can continue the pregnancy till term and deliver the baby. And then look at the baby, see how the baby is. If the baby is stable, tolerating the heart block. We have even sent children home with heart block because they don't satisfy any of the other criteria for pacemaker placement. But if there is high drops, then the whole thing changes, immediately changes. You have to get ready. You have to make sure that the delivery happens in a specialized center.
So which babies would you do the drug, the orsipranolin, what they used then?
Yeah. So we use drugs like orsipranolin given to the mother in fetal life in order to try and increase the fetus's heart rate. And we can monitor and see whether the fetus heart rate is improved. So in babies who have heart block, if we are monitoring and we start seeing signs of high drops, we start using salbutamol or terbutaline or orsipranolin right away. After birth.
In the mother.
In the mother, yeah, because we want transplacental treatment for the baby. Correct. After birth, once you have lines in, it depends on whether you are at a point where you're immediately able to open the chest and put a temporary pacemaker or not. If you are, then there is probably no need to get orsipranolin, etc. organized. But if you cannot, if there is going to be some kind of a delay, then obviously you need it.
Okay. Someone has asked the question, what would be done antenatally to prevent high drops? I think the medications that you mentioned would prevent to some extent, right?
Yes.
Then, well, there's another question, a little bit complex. Will AV desynchrony not compromise diastolic filling of the ventricle? What about stasis and atrial clotting or possibly atrial fibrillation as a result if asynchrony?
So atrial fibrillation is almost unheard of in newborns. You need to have some kind of a critical atrial mass in order to have atrial fibrillation. So we do not typically worry about atrial fibrillation. Okay. These are all theoretical concerns. The immediate concern is an improved heart rate. Getting the heart rate somewhere to the physiological range. Sometimes even these babies don't tolerate heart rate in the physiological range. You may have to slowly increase the heart rate. So if the baby's heart rate is, let's say in this case, 70, and we put a temporary pacemaker, you notice that they were pacing at 130 beats per minute. We have had cases where we had to pace at 90, then slowly go up to 100, 110, etc. But the most important thing is an improved ventricular rate. AV synchrony is helpful, but not critical.
Okay, makes sense. Another question is, how well is orsipranolin studied for use in neonatal bradycardia?
I don't know how well it has been studied, but it has been used, as far as I know, for at least the last 20 to 30 years. Doesn't uniformly help in everybody, but our options are very limited when it comes to transplacental treatment in these cases. And so I don't think we have anything else to use. Hydroxychloroquine has been shown to be helpful in babies who have early signs of heart block. I saw a question somewhere, what should we do if there is first-degree heart block? If you start seeing first-degree heart block or second-degree heart block, typically you start hydroxychloroquine in the mother and steroids. There are large studies going on, but this is a relatively rare condition. And so getting enough expertise to be able to say this is a standard treatment for all these patients has been very difficult in this field. So people are trying.
Okay, I'll go on to case 2. If you can see the slides, in the interest of time, I'll try and see if we can get through case 2. We may not get through case 3, I think, but case 2 should be still very interesting. Dr. Manoj, am I all right with this?
No, screen needs to be shared.
Oh, I don't know, for some reason, again, I'm going to do it again.
Very interesting question.
If this is a 1 hour session, we only have 10 more minutes.
I think to close the first case, there is a very interesting question. Are pacemakers covered under Ayushman Bharat
Yeah, I
packages?
have responded to that question that the Ayushman Bharat scheme covers only a small proportion. It's the whole scheme is very much biased towards procedures, not towards overall care. And you know, in newborns, the overall care is way more important in terms of consumption of resources rather than the simple act of putting in a pacemaker. So typically we struggle when we come to trying to get government schemes to support patients who undergo these kind of care. This understanding that a newborn requires a care which is much more than just doing the procedure has not sunk in when it comes to the policy makers who are looking after not just the Ayushman Bharat scheme, but any scheme that exists in this country. There is this complete lack of understanding. So that's the problem.
Can I interrupt at this point with the permission of the moderators?
Yes.
NNF, National Neonatology Forum, has a role in advocacy, and we are in touch with a few of the respected members of the Niti Aayog for this. So if this could be represented as a proper scientific representation, we could do our part in following up this, because this is something that would benefit a lot of babies.
KK, can I show one slide, please?
Yeah, please do. Please do. I'll just stop sharing and then have you show it.
Let me see if I can show this slide. Are you able to see my slide?
Yeah, I started screening. I mean, I can see that it started to come. Yeah, there you go.
Are you able to see this slide that
Yes.
I'm showing? This is a recent thing. So Medtronic has come up with what is called the leadless pacemaker. As you all probably know, this is a pacemaker that looks a little bit like a capsule, and it is there in this picture right here.
Yeah.
And it can be placed through a large sheath. This is being mainly used in adults. The sheath size is like 23 or 25 French. So it's an extremely large sheath, and it can be placed into the ventricular myocardium, and it's a single chamber pacemaker. Okay. There are other companies, Abbott has got a similar one, etc. But anyway, what Medtronic has done is, in this picture, if you see the baby, you can see the size of the regular pacemaker and then the size of this new IPG. By taking the micra, and incorporating it into a tiny little plastic container with the ability to attach a lead from the myocardium, it converts the micra from being a leadless pacemaker into a pacemaker that can be used like a standard pacemaker. But it is still a single chamber pacemaker. It is a very tiny pacemaker. And as far as I know, the Microny has been hard to get. The company at one point, 2 or 3 years ago, actually decided to stop production. There was a huge hue and cry from the pediatric community. They reinstated production. But anyway, it is also difficult to get. What we do typically when we have a patient in utero, we start activating this. So currently this Medtronic Micra IPG is only available for emergency use for us. So we have to get a special dispensation from the company. We have to get a special ethical committee approval from our institution, which all can be done within 24 hours. Then the thing is FedEx to us. We have it ready and waiting in order to place it in the patient.
That's terrific. But again, we are going to be daunted by the cost of this device, which we know is very expensive in our context, about 5-6 times the cost of a pacemaker. Nonetheless, it's still a very good option if the patient is able to afford.
Yes.
So I now, if you can stop sharing, I'll start with the next case. With the kind permission of Dr. Manoj, we'll take about another 15-20 minutes to discuss the second case. Is that acceptable?
Sure, sir. I mean, from our side, it's all okay. If you are okay, we can continue.
Thank you so much. I will request Dr. Navaneetha, my colleague, to take over. And maybe, Navaneetha, are you in a position to share and start the second case? That will be nicer if you run this because you're so familiar with this case.
We can share from here, sir. No.
You share from there, and I would like you to take charge and make sure that we give this. Maybe we'll not go through the third case, but the second case certainly is worth sharing, right?
Yeah.
And then
Sure.
you could engage the discussion with Dr. Balaji. Dr. Balaji, you are familiar with this patient. So
Yes.
we've consulted you on this patient earlier. But this is entirely from the point of view of the neonatologist. So we'll try and give this.
Share screen.
Shakti, my first year DM resident will be presenting the case. Shakti, are you in a position or shall I
Yeah,
share
sir.
for you?
You can share.
I'll share. It will be better. Huh? So I was almost on the verge of sharing. So I will share this case. Go ahead. Shakti, here's with the second case for you.
Sir, one thing, sir. So should we, if we have only one case, should we show the second one or third one, sir? The third one is the one with the.
We will
Whichever
show
is simpler,
very
whichever is
briefly.
simpler.
Okay.
Whichever, I would suggest whichever is from the neonatology perspective, because majority are from the neonatology side. So
Don't worry, we'll do
neonatal
this and
perspective.
then we'll figure out a way to discuss the third case. But just go ahead and show this.
Go with the first one.
Yeah,
Yeah.
sir.
Which is-
Moving
which
on
is
to my. Yes, sir. Moving on to my case. So this is a term child with no family history of any congenital heart disease or genetic or neurological disorders, was delivered via emergency LSES in view of fetal bradycardia. Then post-delivery child had probably had a normal heart rate, hence was shifted to mother's side, and no further monitoring was done for the next 24 hours. All delivery happened in outside institute. By the end of 24 hours of life, the child had multiple episodes of seizures, and hence the child was intubated and referred to our institute. On arrival, the child was in spite of recurrent seizures. The child was active, alert, with no visible birth defects. But other than that, the child had marked bradycardia with a heart rate of 65 beats per minute. Next slide. So with this presentation, our initial evaluation started with ruling out neurological and infectious pathologies. Since both turned out to be normal, our further differential were electrolyte abnormalities, which will also explain all the features of both recurrent seizures and bradycardia. And our last differential diagnosis was cardiac evaluation, and out of that, echo was also normal. Next slide. So this is the ECG at admission, where you can see 2:1.
Don't interpret. We will just, I would like you to go slow and let Dr. Balaji take over at this point in going through in a way that the neonatologist will understand what is happening.
Yeah. So again, this is, in some respects, it is similar to the previous case. You can see that there are lots of P waves. Dr. KK is pointing to the P waves and not that many QRS complexes. So first thought in anybody's head would be, this is some kind of complete heart block. Okay. But there are two other features that you have to, if you look very carefully, you will see. One is, every time there is a QRS complex, it is preceded by a P wave. Whereas in the previous patient, sometimes the P wave was before the QRS complex, sometimes it was after the QRS complex. So as you know, one of the rules of sinus rhythm is a P wave precedes every QRS complex, and a QRS complex is preceded by a P wave. In this case, every QRS complex is preceded by a P wave, but there are other P waves that we can see. Now, it is very easy to miss these other P waves if you only look at one lead. Okay, let us say, for example, you are looking at lead V5 or V6 or even V4 on a monitor. The P wave is very small. That second P wave, which is hiding, is very small. So one of the basic rules of electrophysiology, as an electrophysiologist, I'll tell you, whenever anybody calls me and says, I've got a patient, I'm seeing something on the monitor, or the monitor looks like sinus rhythm, but the child is not looking well, etc., etc. The first thing I always say is, get me a 12-lead ECG. That's like a dictum for electrophysiology, because 12-lead ECGs have 12 times more information than 1-lead ECGs. Simple math. And when you look at the ECG from different angles, lead 1 or lead 2, each one of these is looking at the cardiac electrical function from a different vantage point. you can see here in lead 2, the P wave is huge. You can see the other P waves. So that is a very, very important factor. Second thing is, in this case, if you pay close attention, that P wave is happening before the T wave. So the ventricle has not repolarized, right? Repolarization, the basic fundamental electrophysiologic property of the cardiac myocardium is two things. One, ability to conduct electricity, and two, after having conducted one electrical beat, it has to take a pause. So think of it like flushing the toilet. Okay, you flush the toilet, then the toilet cistern has to fill, only then you can flush it again. Same thing, it has to repolarize. In this case, the repolarization is not yet over, and there is a P wave. So naturally, this P wave is not able to activate the ventricular myocardium because the ventricle is still repolarizing. It is not yet ready for a depolarization. So this is a very important finding, and this is what we call pseudo heart block. It is not true heart block. This is 2-to-1. There is a 2-to-1 relationship. First of all, you can see there are 2 P waves for every QRS complex. And it is a functional block. It is not a true block. Many of these patients turn out to not have AV nodal problems. When we see this phenomenon of a very, very prolonged QT interval, the T wave is very delayed, and the ventricular repolarization happens after the second P wave. This is pseudo 2-to-1 AV block in somebody with a very prolonged QT interval. Now,
Wonderful.
you know,
Yeah,
fundamental of medicine is 90% of what we do is pattern recognition. As a neonatologist, you have certain patterns in your head. You see a certain type of baby, you know immediately what to do. For us electrophysiologists and cardiologists, this is a pattern that has been drilled into our heads. Okay, it may not be in your head, but it is in our head. So the important thing is, if you are not sure, you have a baby with bradycardia, you think, oh, you know, I'm not sure is this just sinus bradycardia or not. Take a photograph, with modern technology, send it anywhere you want, and just ask a quick question. I have a baby like this. This is the ECG. What should I be worried about? Send it to your cardiologist. And I can assure you 90% of them will look at this and immediately go, this is what is happening. This child has a very, very prolonged QT.
That's exactly what we often do with Dr. Balaji. We send even whatever arrhythmia that we find difficulty in interpreting, we share with him. So, Shakti, you can continue, Shakti. And Navaneetha, you can also help with discussion.
So in this patient, one point that I would like to mention is in the presentation, the day 1, it was reported as recurrent seizures, and there was no particular reason found for that, and the child had an absolutely normal neurological examination as well. So there is a possibility that the child may have had events at that time secondary to this long QT as well.
For reasons that are difficult to explain, many of these patients have what we call non-sustained runs of ventricular tachycardia. So they go into ventricular tachycardia and they come out of it. I mean, obviously, not everybody comes out of it, and this is one of the causes of sudden death. Long QT syndrome is one of the most important causes of sudden death. It can be an important cause of sudden infant death syndrome also. But in many of these patients, they come out of it. So whenever we are worried about long QT in any patient, we always ask for family history of seizures, not just family history of sudden death. So they can present with anoxic seizures. And I am pretty certain that in this case, most likely the so-called seizures were from ventricular arrhythmias. In fact, I was involved in a court case one time. A patient had been treated for intractable seizures with multiple changes of anti-epileptics for many, many years, for over a decade. and then had a cardiac arrest, was resuscitated, and ECG was done and showed long QT. This happened in the USA. It's not in India, in the USA. And the patient survived, but had some neurological deficits. They took the neurologist to court, saying they were doing management of intractable seizures, but never even once bothered to look at an ECG, bothered to do an ECG. And if you look at the story of that patient, every time the patient had a seizure, there was some kind of a sudden scary event, like an alarm bell going off. This is classic long QT behavior. When there is a sudden surge of adrenaline, it can put these patients into ventricular tachycardia. Okay. So the lawyer contacted me and said, the neonatologists are saying that they don't do ECGs on patients with seizures. I said, they may not, but in this case, they should have. The story is so classic. You say the same story to a cardiologist, and the first thing they will say is long QT syndrome. In fact, they will even say long QT syndrome type 2. It is such a specific story for us. So not thinking about other possible causes of seizures can be a problem. So in fact, what we now say is any patient in whom you have unexplained seizures should get at least one ECG to make sure they don't have this long QT or one of these so-called channelopathies.
So Shakti, you should describe this ECG.
Yeah, sir. So this child had a significant hypocalcemia and hypomagnesemia, but even after correction of the hypocalcemia and magnesemia, this child had the persistent long QT, and you can see the leads V3, where you can see the alternative T wave changes morphological. That is, one T wave is long and deep, and the next one is small. This is called as T wave alternance, and which is more characteristics of a long QT syndrome.
So rule of thumb for non-cardiologists, the T wave should, if you take a QRS complex and another QRS complex and put a line right in the middle of the two, at about 50% between the two, the T wave should have ended by that time. Okay? If you don't know how to calculate the QT, how to calculate the rate corrected QT, etc., don't worry about it. This is prolonged because this T wave goes almost all the way to the next P wave. Yeah, at this time, this baby is in 1-to-1 conduction. So this again, same baby. So we know now by looking at this ECG, the previous ECG with 2-to-1 was not due to an AV node problem. This again confirms that. And you can see how long the QT interval is because the T wave is so long and ends right before the next P wave.
It's a beautiful example, Dr. Balaji, because it's paradoxical in these patients. If you slow down the sinus rate, you actually increase the heart rate, because that's what happened in this child. Once the sinus rate slowed down, the 2:1 disappeared, and you could have a slightly faster heart rate, which is very interesting. So go on, Shakti, please.
Yes, sir. So next slide. So once our diagnosis of long QT syndrome was done, we initiated the child with the propranolol and mexiletin. With the characteristics, since the T wave changes were more towards long QT type 3, we started a mexiletin, which is basically a sodium channel blocker, and long QT type 3 is a sodium channel blockade problem. So we started mexiletin.
So the most common cause of this kind of extremely prolonged QT with 2-to-1 conduction, etc., is long QT type 3, which is a slightly different long QT. Currently there are at least 17 types of long QT that have been described. We have gained a lot of knowledge about genetics and so many different aspects of long QT. But even though there are 17 types, type 4 to type 17 are very, very, very rare, incredibly rare. And this happens to be one of those cases. But type 3 is not that uncommon. Type 1 is about 50 to 60% of cases. Type 2 is about 25 to 30% of cases. And type 3 is about 5% of cases. And all the other types come afterwards. So the mainstay of treatment, and as Shakti said, this is a genetic disorder, type 3, with a gain of function of the sodium channels. So if you remember your action potential, you have a sharp upstroke, and then a long tail, which is the repolarization, right? So that repolarization is prolonged in these patients, okay? This can happen, most commonly this happens because of a potassium channel defect. The potassium, during depolarization, sodium gets into the cell from outside. The potassium goes out, and then repolarization, the potassium comes back in, and it takes a long time, and there is a what we call the action potential duration. So in these patients, one of the fundamental problem is prolonged action potential duration of all the myocardial cells. Now, gain of function of the sodium channel means there is leakage of sodium current during repolarization, which is going to prolong it. So this is a gain of function mutation, not a loss of function. And because it's a gain of function and overactivity of the sodium channels, sodium channel blockers have a role in the management. And mexiletine is an analog of lidocaine. So lidocaine is what we call a class 1B, B as in Bravo, antiarrhythmic. There are basically 3 drugs in this class: lidocaine, mexiletine, and phenytoin. And many of you probably have used phenytoin for seizures, etc. So these 3 drugs are all sodium channel blockers, and they are very, very useful. So for example, if you have a patient like this, who's having arrhythmias in front of your eyes, who's having recurrent ventricular tachycardias, the mainstay of treatment is intravenous magnesium first. Magnesium used as a pharmacologic agent, not just to correct the magnesium disorder, but magnesium used as a pharmacologic agent. And the second drug you should reach for is lidocaine, intravenous lidocaine. Third drug should be a beta blocker, like intravenous propranolol, etc. So this is excellent that the child was immediately started on propranolol and mexiletine.
Okay, Shakti.
So following the diagnosis, everything was going well until the child developed Klebsiella pneumonia sepsis and necrotizing enterocolitis with pneumoperitoneum. So requiring surgical intervention. So peri-surgical period, the child was withheld of propranolol and mexiletine temporarily. And post-surgery, the child immediately went for an asystole, requiring chest compression and revived after 2 cycles of CPR with adrenaline. So this is the ECG, which you can see, which was done immediate post-cardiac arrest revival, where you can see the QTC has prolonged much more, 690, and at this time, the child was not on any antiarrhythmic. So again, after this, we had to restart mexiletine and phenytoin, and the child was again slowly stabilizing in a way. The pneumoperitoneum was settling and everything was settling down. And immediately the child one day had a massive GI bleed, for which endoscopy was done and found to have a severe esophageal erosions. And this esophageal erosion is possibly due to the most known complication of the mexiletine, because possibly the dose which we are using for mexiletine is a pediatric dose, as there are no strict dosage for the newborn. And hence, after mexiletine was withheld, we had to restart another sodium channel blocker. And this time we preferentially used phenytoin. And with phenytoin and propranolol together, the QT6 slowly came down to 479 milli per second. And the genetic testing was sent. And after 1 month of NICU stay, the child was discharged. The genetic testing came out to be a COM1 genetic mutation, which is one of the severest form of long QT syndrome.
And one of the rarest.
So the current status is the child is now 2-year-old with no major cardiac events, attaining normal developmental milestones. In spite of the medication of propranolol, phenytoin, and restarted mexiletine, because the QTC was prolonging furthermore in spite of these medications. So the current weight is 11 kg, asymptomatic, but still, in spite of these medications, the QTC is still prolonged. So we have the possibility of ICD and sympathectomy is being considered.
So initially till around 18 months of age, with the propranolol and phenytoin alone, the QTCs were decent in the sense it was like around 500, like 490, touching on 500. And then as the child neared around 2 years, then what happened was we found that the QTC was prolonged again, like much more than 600 at times. And then we thought that probably we should consider reintroducing mexiletine. So the child was admitted and under proper monitoring and under proper care that the GI issues do not happen. We had reintroduced mexiletine slowly and built up the dose. As of now, luckily the patient has not had events again, but then the highly prolonged QTC, which is persistently more than 500, is considered to be a significant risk factor. And this particular gene, the calmodulopathy gene, as was mentioned by Balaji sir, it is one of the rarest and one of the most malignant of long QT syndromes and most difficult to treat. And hence, we are considering, the other steps, further steps than medications like sympathectomy and or ICD placement.
I think in the interest of time, we will stop here. And I know that you would want to see the third case. I'll only show you one ECG from the third case, which is worth showing because it illustrates something else that happens in long QT syndrome. So I'll just show you that and then we can go on. So this is the ECG that Dr. Balaji can just briefly discuss. And in the interest of time, I'm trying to just show this and then we'll move on.
Yeah, so this is a characteristic ECG in long QT. This is called torsade de point, and it means twisting of the points. So this is a form of ventricular tachycardia / fibrillation. You can see the QRS complexes are changing all the time. So it is a form of polymorphic ventricular tachycardia. So morphology is changing, but you can also see this waxing and waning effect. The QRS complex is getting bigger, smaller, bigger, smaller. So this is when you find this, your default diagnosis should be, this is long QT syndrome. It's a very characteristic ECG in long QT syndrome.
So this patient story is also very interesting, and maybe we can do another session later on neonatal tachyarrhythmias, and this would fit in there as well. So I would, because in the interest of time, and also the fact that we need to engage our moderators in some discussion that neonatologists can relate to, I will stop the presentation.
KK, before you stop, can you just show that one slide that I sent you?
Of course, absolutely. I'm so sorry.
So
do that.
In 2020, after a lot of discussion, mainly between myself and Dr. KK, we came up with a program called Children's Heartbeat. So Children's Heartbeat is a program that basically I am running from here, and it is always happening. It always happens on the last Friday of every month. It's at 7 a.m. my local time here in Western United States. And so right now during the winter time, it's at 8:30 p.m. for India. During the summertime, it's at 7:30 p.m. Basically, each session is about 1 hour to 1 hour, 15 minutes. Sometimes we go up to 1.5 hours. Like an interesting case is presented. And then I usually get a panel of experts to join the session. And there is basically a long discussion, very similar to what you've seen here today. But in the, today we only had like 3 experts. Sometimes for these sessions, we have quite a lot of experts and we discuss it thoroughly, look at basically at ECG tracings, look at the story and discuss, what do we learn from this case? How could it have been managed, et cetera, et cetera. And at the very end of the session, for about 10 minutes, maybe 15 minutes, one of the electrophysiologists gives a short presentation about what is pertinent. What does that case illustrate? What do we need to take home from that case? So if you scan that thing that says scan me, it'll give you a link. You can register for this program, or you can always send me an email. My email address is at the bottom and my secretary can take care of registering you. You have to register. Registration is free. And the other important thing is if you're registered, you will get the recording. So say you're not able to attend a program, it doesn't matter. You can always go back and watch the recording of the program. Thank you for giving me the opportunity to tell you about this program.
Wonderful. And now I will hand over the stage to Dr. Agrawal and Dr. Bilagi, and with a sincere apologies for extending the time beyond, these are things that take time to discuss.
It's a pleasure to get wisdom from both of you, and hope we would have some change this wisdom to our heads. So we neonatologists also have some things in our head. Professor Balaji told that when we go to NICU, we take rounds and we have some pattern which we follow, and every department, every specialist follows that. So definitely passing on to that simpler things and making ECG, reading ECG for neonatology is really, really, I would say, encouraging, and we would love to hear further from you in further sessions. So I think we don't have any questions on the long QT thing, but I just wanted to bring up one thing. So we have used max self infusion for long QT. I think 5 years back, I used to in one baby, advised by a pediatric cardiologist. So can we consider max self in such cases?
Yes, absolutely.
But before, so one thing, that point that Dr. Balaji made, and I would vouch for it, is let's use this whole forum to create a group, sort of, I don't say a formal group, but a mechanism by which you can share your ECGs.
Sir,
Let me emphasize. Yeah, I know. I'll just complete 1 minute. There is tremendous value in coming to an accurate diagnosis of the arrhythmia and giving the exact treatment. And all this is possible remotely for ECG better than any other means of diagnosis. So if you have a WhatsApp of the ECG, you can get the world's best opinion within a reasonable time.
Sir, can I give the answer to this?
Yes.
We National Neonatology Forum this year is in the process of launching a platform called DigiNNF, where
Yes.
one of the sessions I was only going to request you only will be, we have interaction with the various experts on various things in this platform. It's something like a neonatology LinkedIn sort of thing.
Yes.
So where one of the things would be neonatal cardiology. And we are going to ask you officially, we are going to request you to lead that. So we will have the digital cardiology in that as well.
Wonderful. And I would strongly encourage everybody, 2 points that, that should come out of this, that Dr. Balaji has said, the 12-lead ECG. Okay. Don't underestimate the value. Don't get misled by the monitor. Please try to get the good data, because there is huge value in getting a good quality ECG. It's well worth investing in that. I'll just give you a small little experience I've had. I've mentored one student from All India Institute, Jodhpur, who has just finished her PhD, her MD thesis on neonatal ECG and preterm ECGs. And she has a wonderful way of doing it with minimum trauma and minimum disturbance to the patient. I can share those slides with you, those pictures, and that'll be of great value to people who are neonatologists. So whenever you encounter an arrhythmia, best is to get the information and then you can initiate treatment.
So I would say 2 take-home points from this session. So 12-lead ECG would be better, and as Professor Balaji told, it is 12 times more powerful than a single-lead ECG. That is one line I would remember my whole life. And second, I would say any unexplained event, seizure or anywhere, please get an ECG. Don't only focus on the symptomatology. Get an ECG and rule out arrhythmia. So I think these are the very good, important points. Yeah.
I completely agree. Dr. Archana, any words of wisdom from you as well?
No, I'm still reeling with the thing with the baby with the refractory seizures, get an ECG. We never really ever think of it, so that was an important point made. And it doesn't, I guess it doesn't necessarily the baby doesn't necessarily have to have a low heart rate for this to occur, right? A long QT syndrome.
Correct.
So
Correct.
Yeah.
Absolutely. And
okay.
And with the same breath, emphasize the importance of family history. Asking about family history of sudden deaths, unexplained deaths, fetal demise, neonatal demise of other children in the family, etc. And I think part of the problem for you guys is also in India, in many communities, there is consanguinity. So
Yes.
consanguinity creates a lot of problems, as you know. Some of the diseases that we very rarely see here because they are autosomal recessive. Okay, you can see there because there is one copy from each parent, right? If they are heterozygous, then they are only going to be carriers. But if they are homozygous, then they are going to manifest it. So family history on both sides of the family is huge.
Right. The session has been exceedingly educational.
Well, thank you very much. Thank you for the opportunity. This has been a very, very interesting session. And I'm really honored that you asked me to participate. Thank you.
I think your inputs were phenomenal, I can say, and I think you really did come to the level that was needed here in terms of not making it very esoteric. Manoj, before we wind up.
So again, I would like to thank all of you, the experts, the panel of experts, and the moderators who have done a remarkable job. We started 2025 in Learn from the Legends with a bang, I must say. This will be a very, very popular session. I must, and I would like to just inform the respected faculty that we